Good morning and welcome to Health Talk, sponsored by Mon General Hospital. This program is designed to provide education on vital health topics to help you take charge of your health. You'll also be introduced to Mon General's committed physicians, allied healthcare professionals, and quality programs and services. And now, here are your Health Talk hosts, Kay Murray and Jim Stallings.
Yes, she is Kay Murray. I am Jim Stallings. This is Health Talk, as the man with a nice voice at the beginning told you. So let's get right into our subject and introduce you to Dr. Jamie Lesnock. First, good morning, Kay. I'm sorry.
Oh, no, that's fine, Jim. I was just thinking about the committed physicians. Should be committed DJs, I think, sometimes.
Probably.
Yeah.
Dr. Jamie Lesnock, a gynecological oncologist. Wow, that's a mouthful. Good morning.
Good morning. How are you guys?
I'm doing just fine. Tell us a little bit about your background and what is a gynecological oncologist?
So I just a little bit of personal background. I grew up in Washington, PA, so I'm a relatively local person, and went to University of Pennsylvania and Vanderbilt for medical school, and I've actually done my last 7 years of training at McGee Women's Hospital in Pittsburgh, where I did an OBGYN residency, followed by a GYN oncology fellowship. So, and GYN oncology, or gynecologic oncology, that's kind of how you can abbreviate it, gynoc.
That's much easier.
Much easier,
You're a gynoc.
Right? Gynoc.
Sounds like a Star Trek villain.
So we have the unique opportunity to take care of women with malignancies or cancers of the female genital tract. So essentially ovarian cancer, uterine cancer, cervical cancers, vulvar cancers, vaginal cancers. We don't typically take care of women with breast cancer, although there are some gynocs that are specialized to do so. So it's a pretty focused group of women that we take care of.
And I'm sure this is like all cancers, early detection, very important.
Absolutely.
Being aware of our bodies and going and having regular checkups.
Absolutely. I mean, I think that women in general, not to stereotype, but I think women in general do visit doctors more frequently than men do.
Absolutely.
And I think women have a lot of opportunities for screening tests that are very good. Mammography for breast cancer, pap smears for cervical cancer. You know, unfortunately, we have some cancers that we don't have screening tests for. Mm-hmm. But like you said, the just knowing your body, knowing those symptoms, seeing your regular gynecologist on a yearly basis just to get that exam and talk about anything that just doesn't seem right with you can oftentimes open up the door to find out what's going on.
The ovarian cancer, a little more difficult in detecting, and it can go beyond to the point where we're really in trouble before we're aware of that. How do we change that? How, even if we're aware of our body, that can happen so quickly.
It can. You know, ovarian cancer is a very scary disease for, the women that unfortunately get diagnosed with it, as well as us as physicians who take care of it. About 20,000 women will be diagnosed with ovarian cancer in the United States, but about 15,000 will die of ovarian cancer. So if you think about 15 out of 20,000, that's a high ratio of, unfortunately, mortality. And so, as of yet, we have some screening tools with some tumor markers and some ultrasounds that are approved for use in women who are considered high risk. But in the general population, we really don't have any approved tests. And so, again, it can come on very quickly.
Blood test, is that?
It's a blood test. One of them is a blood test. But again, it's not a screening test per se. We use it for women already diagnosed. But
I've often wondered why, when we do take care of our bodies, we go to the doctor, why we cannot get that blood test. Every time you go once a year, why not do that? Is it too expensive, or some way to track it? Because we know it can be a silent killer.
Yeah, so that blood test, unfortunately, it can be elevated in so many other conditions that it actually could then be a false marker and lead to interventions that otherwise can have their own complications. So for instance, you could get that blood test and it can be elevated if you have a bowel disease. And so let's say it's elevated and the doctor takes you to surgery and you have a complication from surgery, and you never had an ovarian cancer problem to begin with. So it's a hard balance to do. So that's why it's not, an FDA-approved test for a screening as of yet.
On the heels of what Kay said about being a silent killer, I was talking with somebody yesterday who was talking about a friend of theirs that started experiencing these pains in his lower back and couldn't understand what it was. And it turns out he had a tumor in there. And so early detection, when you talk about these screenings, that's well before we would start feeling any signs or symptoms, correct?
Correct, right. That is exactly what the pap smear and a mammography is meant to do. So a pap smear, it's recommended that women get it every 1 to 3 years, depending on their age and other factors with the women. But a pap smear is you don't really feel anything, and so the point is to get that, and so to see if you have any pre-cervical cancer lesions or any areas that are abnormal to take care of early on.
When you get that swab or take it to the lab, I mean, are they finding cancer cells? Or is that what they're looking for?
Yeah, so they're looking for either cancer cells or what we call pre-malignant changes. And so in the spectrum of what the cervix looks like under the microscope, there's completely normal cells and there's cancer cells, but in between there are actually cells that look abnormal but aren't cancer per se. We have ways of treating those, either with just cutting out part of the cervix. Sometimes we can actually use lasers, we can freeze it, and so that is that pre-cancer stage that we can treat with much less invasive means than if you actually had cancer diagnosis.
But if you wait too long, you're a procrastinator, you don't go to the screenings, by the time you start feeling pain from cancer, it's well past the early detection stage. And I don't want to say it's a death notice or anything like that, but it's advanced to the point that it's a serious, serious issue.
Correct, yeah. I mean, a lot of times, pain is one of those symptoms that our body tells us that something is not right. And so a lot of times that, yes, you may have you may have a more advanced disease, whatever, the cancer type is.
But we know so much more today than we did 15, 20 years ago.
Oh, absolutely.
And those things are progressing, and in time we'll probably see more changes. And what have you seen in your last 5 years in the changes of people being able to survive cancer more and more all the time?
Yeah, no, I think in a lot of ways many of the cancers we treat are becoming more of a chronic disease in the sense that we're able to, so for instance, ovarian cancer, one of the newer treatment modalities is something called IP, or intraperitoneal chemotherapy, which is, where essentially the chemotherapy is put into the abdomen as opposed to the IV. There's actually a combination of IV and intraperitoneal. This type of chemo has been around for actually many years, but just over the past 5 to 7 years have there been studies that show that it is definitively better for women who have a subset of cancers that we're able to take out surgically and then treat them with this chemotherapy, and they're living upwards of 5, 7, plus years beyond their diagnosis, which, look, 10, 20 years ago was kind of unheard of. Yeah. And so I think and that type of chemotherapy, Dr. McBee and myself are very strong advocates for. We give that chemotherapy at Mon General. We recommend our women who we see with ovarian cancer at Mon General but maybe live, in Cumberland or Wheeling. We try to speak with a medical oncologist there to recommend that when we feel strongly that that's an appropriate treatment for them.
Our guest is Dr. Jamie Lesnock, and she has joined Dr. William McBee as part of the Zelda Stein Weiss Cancer Center. And we invite your phone calls at 304-296-0041. Health Talk on WAJR continues right after this.
This is Mon General's Health Talk, providing the information you need to take charge of your health. Call us now with your health-related questions at 304-296-0041.
Dr. Jamie Lesnock, a gynecological oncologist, and we're talking about cancers of the women's lower area. How about that?
Cervical cancer, ovarian cancer, and
lower regions.
Vaginal cancer.
Vaginal
vulvar
cancer.
cancer, yeah.
Everything that that really is scary for
absolutely.
women. Just the word cancer
Absolutely.
is scary. And before we move on to surgeries, invasive, non-invasive surgeries, I did want to go back to research going on, because a lot of money goes into research.
Absolutely.
And what do you see? Of course, our ultimate goal is no cancer, wipe it off of the face of the earth.
Right.
But where are we going from here in detecting? And is there something on the horizon?
Yeah, I think that two things. First of all, there's kind of a whole field of research that's called translational research, and it's meant to say, when does the medicine that happens in the laboratories translate? How does it translate to the patient who's in your office, and how does that help you? And so this is kind of a whole field that's evolved over the past couple of years, and I think this is the next realm of research that is really important, because basically it takes individualized patients and women and tries to look at either markers in their blood, markers in their tumors that somehow signify what's different about their tumor and how we can treat it differently and give a more individualized approach. And I think that's how research in kind of our big cooperative group. So there's one main cooperative group called the Gynecologic Oncology Group, the GOG group, that Dr. McBee and I are affiliates of the University of Pittsburgh Center. We're actually starting to open up our first trial at Mon General as an affiliate of them. But as we start to open up more trials, a lot of those trials, even though they're meant to enroll women to try new drugs, they also have a component of getting blood, getting tumor samples to try to test for these things that in the laboratory, can we find out, is there a different protein, is there a different genetic alteration that caused this woman to have cancer, or can define what is the best way to treat her. So I think those are kind of things that are near and dear to my heart that I did a lot at McGee and would like to continue at Mon General. And also, the GOG studies are really just a great opportunity. Again, these are trials that enroll women across the United States. Ovarian cancer, cervical cancer are such rare cancers, in the grand scheme of things, that we need people all over the country to be trying these new drugs on women to try to figure out how are we going to cure this disease. Because
I think you hit on something there. The first thing we say, if a family member or someone we love, why? And that individual saying,
right.
Why me?
Right.
And you do ask that question because you may get lung cancer and you've never smoked a cigarette in your life, or you may have been very fit and you get ovarian cancer or cervical cancer. Have you been able to pinpoint why in some cases you mentioned obesity, lifestyle, does any of that play into some of these cancers?
I think absolutely all of them play into it in multiple ways. Unfortunately, there's very few cases that we can say, this caused this. There are some genetic alterations that significantly increase your risk, but for most cancers that women and people in general will get, it's a combination of that. We know obesity is associated with many different types of cancer, ovarian cancer, endometrial cancer also. Endometrial cancer is actually the most commonly diagnosed GYN cancer, female cancer, aside from breast cancer, and so obesity is clearly linked to that. So that's kind of a lifestyle thing, obesity is one of the things, obviously, with heart disease, strokes, but also cancer is a big thing that we, if we can work on counseling women to kind of work on their weight and that kind of thing as well. But you're absolutely right, smoking, genetic family history, and maybe not just genetic things that we even know how to test for anymore.
Was going to ask you this before the break, but we'll take a break and I'll ask you afterward about the HPV vaccine, whether it's working, whether young ladies are getting the vaccine or not. We'll talk about that when we come back in just a moment here on Health Talk on WAJR.
The doctors, the latest news and procedures. Your local health connection is Mon General's Health Talk. If you'd like to be on the show, call 304-296-0041.
The human papillomavirus causes most cervical cancers. and there is a vaccine for that, the HPV vaccine. And Kay and I, we were learning about this several years ago. It was controversial at first because some moms didn't want their daughters to get this vaccine at the age of 9 or 10 because they thought it led to an open door to sexual activity. Tell us about the state of this vaccine now. Are more and more of our young women in the population getting the vaccine, and have we seen a decrease in the number of cervical cancers?
I think we're making some progress. I think now that we've, as physicians have highlighted how well this vaccine works and have proved the studies continue to be updated. We have data that's 10 plus years now showing reductions not only in the rate of cancer, but also when I talked about those pre-invasive lesions, which, ultimately, if not treated, will lead to cancer, but require their own interventions, have led to reductions in those. Do I think we're at where we need to be in an ideal state? No. I think there's still, some not pushback, but, some concern, in the community with, again, children getting these. Why do girls need to get it so young? And I think what people need to understand is you can be exposed to HPV the very first time you have sex. And the point of the vaccine is to build up an immunity prior to that exposure. So even though you can still give it after having sex and being exposed, and there's some protection there. The goal is just like, if you think about why we give children vaccines at 1 year of age to prevent measles, mumps, all that kind of stuff. It's to build up that immunity prior to exposure. It's been proven over and over again to be very safe, and it is very effective. There's actually 2 vaccines out right now. They differ slightly in what types of HPV they cover. But, and then I think another issue is insurance coverage. But the other thing I like to encourage people is that even if your insurance doesn't coverage, we have lots of ways of getting vaccines covered for children because we, believe so strongly that they're important for them.
We usually don't take our little girls to the doctor or gynecologist at that young age. I mean, it's usually we wait until they start their menstrual cycle. How do we get the education if we have a young daughter to go forward and to come to a doctor about this?
Well, and I think that's a great point because I think that points to who's giving vaccines to children, and it's mainly pediatricians, family practitioners, and that's where the onus is a little bit on us as gynecologists to get these physicians to give the vaccines, because you're right, there's really no reason for a 9-year-old girl to come see a gynecologist. That's a scary thought for her, but I think as mothers, we can, if maybe our pediatrician isn't knowledgeable or unsure of it, then most certainly as the mother's gynecologist, we can make recommendations or provide that vaccine if needed.
Let's go to the senior citizen here for just a moment. We have about a minute left in the show, and that is there a time in our life where it's not as important to go and have a pap smear every year, or our chances of getting cervical or some of the cancers we've talked about today, they decline?
Yeah, I mean, I think without going into the details of all the recommendations out there, in general, when you start to get around 65, 70, 75, the recommendations differ, but, you have to start balancing, not to sound too harsh, but there are other diseases that could take your life more quickly than cancers. And so around that age, you should discuss with your physician. And
discuss with our physician about screenings. We can probably get that done through the Zelda Steinweiss Cancer Center.
Absolutely.
And that's through the number at Mon General Hospital. And again, mongeneralhospital.com. Is that it, Greg? What's the web address?
It'd be mongeneral.com. That's correct.
Oh, just mongeneral.com.
We try to simplify it for everybody.
All right. Thanks for talking into the mic there. Appreciate it. It's 8:59. You've been listening to Health Talk, brought to you by Mon General Hospital. Thank you so much, Dr. Lesnock. We appreciate the information.
Thank you all for having me.